My name is Eva Slowecki. I'm the Executive Director of the Canadian Society for International Health, CSIH, and I'm pleased to welcome you to this session. This workshop is part of the Canadian Alliance in HIV and HCV Knowledge to Action program. We call it K2A, and it is implemented in partnership with the Canadian Association for HIV Research and funded by the Community Action Fund of the Public Health Agency of Canada. All right, that was quite a mouthful.
Take a breath.
That was quite something. So I'm going to give you a quick bit of background about CSIH, then I'm going to speak about the Knowledge to Action program and then introduce Erica, our main session speaker. So CSIH, if you don't know about us already, even though you're here, we were established 40 years ago when we've been home to the global health community in Canada ever since. We have over 500 members, individuals with an interest in global health and development. So I'm sure many of you are members already. If you aren't, then please feel free to look into us and join. We are a partner for Canadian government and non-government organizations in all our activities. And we're now undertaking a strategic planning exercise to ensure that we stay relevant and stay effective for the years to come. And we have been working internationally and domestically on global health issues, and in particular, viral hepatitis. So, as I previously mentioned, this session is part of the Canadian Alliance in HIV and HCV Knowledge to Action. I'm just going to call it K2A from now on because that'll just make my life so much easier. And this is a set of activities that aim to consolidate collective skills, expertise, and networks of the two partner organizations, CSIH and the Canadian Association for HIV Research. And we're really appreciative to be working together with CAR, and in particular their Executive Director, Andrew Matejcic, who is not here right now. But thank you, we appreciate that partnership. So the K2 Alliance between CSIH and CAR focuses on program science, which also goes by many other words. And there's a lot of nuances too, which you will get an understanding of throughout this workshop. But one of the definitions we have is it's the systematic application of theoretical, empirical, scientific knowledge to improve design, implementation, and evaluation of public health programs. So our overarching goal is to enhance existing capacity and build new expertise in the field of program science with partners and stakeholders, with the aim of improving the health and well-being of people affected by HIV, viral hepatitis, and sexually transmitted and bloodborne infections across Canada. The objective of the K2A program is to build partnerships between HIV and HCV researchers, community members, clinicians, public health professionals, and other stakeholders. So activities that we engage in as part of this alliance will include participation of HIV and HCV service organizations and persons living with HIV and hepatitis C. And as an ongoing activity, the Alliance will measure the collective impact of the activities implemented. So we will be asking you to complete the sign-in forms along with the evaluation, and these forms can be found on your table. So I thank my colleague, Ekaterina Damian, who has organized this activity. And it is now my pleasure to introduce Erica Di Rogerio, the session presenter. Erica comes with a one-page bio, which she has asked me not to read, but
please don't.
I will.
Don't read it.
I will just explain that Erica is the Director of the Office of Global Public Health Education and Training, Director of Collaborative Specialization in Global Health, and Assistant Professor at the Social and Behavioral Health Sciences Division at Dalla Lana School of Public Health. So
that's
all this
enough
to say she knows what she's talking about.
Oh,
and
sure.
Over to you, Erica.
Okay, thank you. Okay, thanks for that kind introduction. Okay, so there's some people back there. If you'd like to come and sit here, I'll give you a moment. I know nobody likes to be in the front, right? Well, thanks for coming out. And so I was asked to speak about program science, and while it is one of the many, many terms in what I'll call the alphabet soup of research, or different ways to approach research problems, what I'm going to try to attempt to do in the next little while is to talk a little bit about program science and how it relates to intervention research and implementation research, or implementation science. These are concepts that are interrelated. They have some overlapping principles. So I'll spend a bit of time going over that. Then I'm going to actually drill down and talk a little bit about some study results that emanate from studies focused primarily in the area of HIV and other related topics. But because this is a workshop, I'm going to be calling on you periodically to interact with me, so that by the end of it, you will also have participated and I will not have lost my voice. So there you go. Is that a deal? And then at one point in the agenda, what I'd like to also do, and I think we can achieve this in your small groups, is to have you work on a bit of an exercise to start applying some of the principles as we go. Since we have a great turnout, and I thank you for that, I would like you, when you do ask a question or contribute, is to maybe just say who you are, at least the first time, and where you're from, because that I think will help to enrich the learning. But I think for all of us who have gone through introductory sessions, we might take the whole time to do that here. So if that's all right. Okay, so let's get started. So I'll just do a quick round of introductions though. Who's a student in the room? Okay, keep up your hand if you're a master's student. Okay, put down your hand. Who's a PhD student? Who's a postdoc? Who's a professor of any kind? Okay. Who works for an NGO? You can put your hand up more than once. We're not doing counting here. Who works for government? Federal?
You mean works or works?
Works, yeah. Jan, you would be all of the above, I think. Bless you. Have I forgotten anyone? Medical student, okay. Well, student, yeah, that counts, but not master's, you're right. Other?
Hospital research.
Hospital researcher, okay. Have I forgotten anyone else? Yes? You're in a university research institute? Okay, great. Well, I mean, I actually think that brief exercise tells you that there are many actors that actually engage in this kind of work, right? Within and outside the health system, in embedded research environments, in community, at government, at different levels of government, etc. So what I want to do is, rather than talk about some program science, implementation research, and the like, in absence of the kinds of problems we're trying to solve, I thought it would be helpful to situate this presentation in the context of what's called a wicked problem. Who's heard that? And I know it's Halloween in 2 days, so I couldn't resist. So, who's heard of a wicked problem? Who's read the 1973 article that it actually emanates from? So, who was born in 1973? No. So there is actually some literature around this, and I think it's kind of slipped into our vernacular to say, you know, all public health and health system problems, all the problems that the Sustainable Development Goals invoke us to take action on, are wicked of some sorts. But what does that mean? So I'm going to talk about that in a moment, then review these different concepts that are up on the stage up here, and then we'll engage in an interactive exercise. So there, wicked problems and global health problems fall into that, are the kinds of problems that require interdisciplinary and intersectoral responses. But they have a number of features. They tend to be socially complex. There's no clear solution. They have a number of unforeseen outcomes, or they involve changing behaviors, and not just individual behaviors. I would argue we need to think a little bit differently about that. So behaviors of individuals, of organizations, of networks, of systems, right? And we'll come back to that, because I know we tend to focus very much on individual behavior change, but I think in our research efforts, including in implementation research, we need to be thinking about different behavior change of different systems, for example. They tend to be interdependent and multi-causal, meaning they have many causes. However, even though we say right up here that there is no clear solution, we tend to come up with very singular solutions to these problems, which is a problem. And so I think, and part of that problem, I would argue, are our methods and how we actually align our methods to study these problems. So I wanted to situate this talk in relation to these kinds of what we call wicked problems. I think another way to illustrate this, and this is based on some work by Don de Sevigny, who actually was involved with IDRC many years ago, right, Sue? You can keep me honest, yeah? And when he had done a fair bit of thinking around systems thinking, basically what he was trying to illustrate is that there are these complex adaptive systems that operate at multiple scales that are really relevant to understanding health and the interventions we design and implement to address them. And these are just many of the different kinds of sectors. Why this is a problem is that often we're working in one of these bubbles or within a very narrow confine, but really the solutions to those wicked problems that I mentioned are at the interface of many of these sectors. So they are wicked problems, and I think part of the reason for that, and as we heard this morning from many of our speakers, we need to be keeping equity at the center. And so a third message I want to leave you with when it comes to these problems is that we need to build in better measures of equity in how we study these problems, but also the interventions that we study. And this is just one of many Lancet efforts that I think underscores the importance of health inequities and the importance to address them. And then finally, I think the other reason that we need to do better, and our research needs to be attuned to that, is when many scholars, including Stuckler and all, took a look at what did we learn from the Millennial Development Goals? I always say millennial, but it's Millennium, right? But I think it's because I have kids who are millennials. But anyway, Millennium Development Goals, or MDGs, that we know that there's been unequal progress. And as I mentioned this morning, part of the problem is that we've really verticalized many of these issues, and we've looked at them independently of one another, and we haven't really been looking at these conditions of vulnerability. So the Sustainable Development Goals, as I said, really outline, I think, a very bold agenda where health is one of several, but again, many of these goals really speak to health and to the intersections that we need to be understanding. So with that backdrop in mind, I thought that it would be important to then reflect on why is it that we need to do program science, and I'll talk a little bit more about that, and implementation research. Like, what are the problems that we're trying to respond to? And more fundamentally, what are some of the barriers to implementing and scaling up interventions? So Yemi and colleagues undertook a qualitative study to begin to answer that question. And some of the issues relate to limited capacity, the poor application of not how you spread knowledge, because we're very good at generating evidence about what works, what's efficacious, but we don't actually do enough research, and this is what calls for program science and implementation research are in response to, at looking at how do things work, under what conditions, what makes them scalable. And those are questions we need to be asking early on in our research designs, not after the fact, right? When we think we can transfer something into practice. Because rarely does that work, especially in the kinds of complex systems that de Sevigny and all have outlined in the diagram I just showed you. We often, and I mean, if I read one more study that says this program failed because the community wasn't ready or engaged, I mean, I don't know about you, but I feel like we've heard that time and time again, yet we replicate that mistake. And we need to be doing a better job at studies that really take into account. And so again, program science, implementation research are in part a response to doing research differently and in a response to some of these things. The other topic that I'll speak a bit about is the context. So you can put lots of adjectives in front of the word context: social, political, fiscal, institutional, cultural. And for those of you who've been trained in epidemiological methods, for example, not that there's anything wrong with that, historically designs that use epidemiological thinking have stripped out context because it's a confounder, it's a nuisance. But yet it does help explain what is that sticky factor in terms of why an intervention gets embedded, why it's taken up in some contexts and others. And so I'm bringing these barriers forward, and I'm sure you have many other examples, to better understand why is it that we've had this call for these fields, in program science and implementation research. You with me so far? Yeah? So leading up to that, are our methods up to the task? So I like to put, and I do a fair bit of teaching on program development, implementation, and evaluation. And one of the things that I think we really, really focus in on is to better understand where a program is at. And that's sometimes very difficult to do, and that's important to get what the message is here is to get a handle on your object of study. And when we're talking about implementation research or program science, we're talking about programs, policies, other interventions, practices as the object of study, as opposed to documenting the problem. I feel like I have a voice in my head because there's someone speaking to me here. If I start to engage with that voice, somebody throws something at me. But anyway, so I guess now what you've been waiting for is sort of what is program science, and Ava read out this. I mean, I would argue that because it's science, it involves something systematic, right? It's the application of scientific knowledge, and something to come back to is what knowledge. Its focus is very much on design, implementation, and evaluation, so hence the reason I put this up in terms of thinking about the different cycles of programs and how they go through very iterative processes. This is very linear, but in the real world it's actually quite iterative, and lots of feedback loops. The more and more complexity that there is, the more likely you're going to see that. It tends to be applied. So in preparing for this presentation, I went back to sort of the assumptions that I held about program science, and unless somebody can correct me, I only see this term used in the HIV literature. Does anybody has, or hepatitis and STI, because those are co-infections and often these terms are. So it struck me as kind of an interesting phenomenon as to why that is. Has anyone else seen it used elsewhere? Tuberculosis. So there seems to be a bit of an infectious pattern here. So I'm not saying that's a bad thing, but what I'm trying to get at is that there are many of these fields that have some overlapping principles, yet they've emerged in different contexts. And that's why I think it's important that in the HIV literature, certainly it's one of the areas where we've seen a fair bit, at least in global health, emphasis on interventions, right? And intervening on populations. And so I don't know the answer to that question, but it struck me as kind of interesting that this focus on program science, where the program is really, and the planning principles are integral to how the science is done, it seems to have been appropriated, at least in this area. But I'm sure one could, that's for a whole other lecture, how these fields develop, right? At any rate, this is a diagram, and Jamie Blanchard, who's at the Center for Global Health at the University of Manitoba, and others, sort of talk about program science as having this interplay between strategic planning, implementation planning, and really looking at issues of quality, scale up, health services evaluation, etc. For those of you who are madly writing notes, I think a sign-up sheet is being circulated. Is that right, with your emails? So you're welcome to have the slides in PDF after. So I probably should have said that earlier, but at any rate, so I think the important takeaway from here is that the program is at the center. It's not a static thing, that it's constantly in design and implementation and evaluation mode. But some of the issues I would argue that program science looks at are not too dissimilar from implementation research, intervention research, etc. So another field, so as you recall from my introduction, I was planning to sort of unpick 2 or 3 areas. So another field that's actually emerged is the field of population health intervention research. And so what makes this a little different, it's similar to program science, is that a program or an intervention is at the heart of it. But in this case, it's very much looking at interventions that have an impact on health at the population level. So I'm just introducing these concepts very briefly. I'm not going to bore you too much longer with definitions, but I think we need to kind of understand what we mean and mean what we say. And in this case, again, the common element is that the intervention is at the heart. But the focus is really on interventions outside at the population level, so primary prevention interventions. So then most of the focus today will actually be on implementation research, and I would argue that this is probably the field that's most relevant in global health and actually has more of the empirical evidence actually comes from global health. And this has come, I think, out of the need to address some of the barriers that I just covered on my slide a few minutes ago. One being that we are not scaling up our programs effectively. We're not looking at the human resource and financial capacity needs to implement programs, and we just expect things that worked under controlled conditions to be sort of thrown out into the real world and be implemented. So implementation research is really, as this definition suggests, looking at the process of fulfilling or carrying something out to its fullest effect. Most of our research on efficacy using RCTs and the like is not about these kinds of questions. And not to say we don't need that kind of research. However, this kind of research goes hand in hand with that. And in many cases, it doesn't answer the kinds of questions that implementation research does. So David Peters, who is a Canadian, but he's at Hawkins, has written on this. And really, he defines it as the scientific inquiry into questions concerning implementation, or the ability to carry out an intention into effect. And so the objects of study, again, are the policies, the programs, or individual practices that make up these different interventions. Others have built on that definition, Edwards and Barker, who've actually written in AIDS journals. And looking at interventions, they put greater emphasis on the contextual conditions and looking at interventions that are scalable in equitable ways. And so I think we heard that loud and clear this morning, that if we don't put equity at the center of our efforts, that's community action, but it's also our efforts in research, then we can actually be generating evidence that may actually increase inequities. So it's really important to look at that. So I think implementation research helps to address that. I think the other thing that we need to bear in mind is that the way you think about an intervention determines how you study it. And so you recall how I was saying that wicked problems do not have a simple solution, but most of our intervention research still to date actually conceptualizes interventions as simple solutions. And so we don't look at them embedded in much more complex systems, looking at different ways of looking at that. And then the other aspect that, again, bringing back the equity component, is that ethical implications are really, really important, especially when we're trying to scale up things through health systems or at the population level. We need to be looking at what are some of the unintended consequences that result from the way we think about the intervention. So in the next little bit, what I'm going to do is just drill down further and then use some examples from the HIV literature. And so I think one of the key things that implementation research is trying to offer are potential solutions and options for overcoming these kinds of obstacles, not just in health systems and sectors outside of the health sector. And so looking at some of the bottlenecks, right? Like, so I know that may not sound like fun research, but it's actually really critical to ensure that interventions reach the people they should, they ensure coverage, etc. So just to conclude this first part, these different fields, I think, coexist, and I think over time we're seeing sort of certain terms take hold, but I would argue program science is kind of at the intersection of many of these things, where what is privilege is programs, but what I'll spend the rest of the time today on is very much drilling in on implementation research, which I think is where we need more research to be done, I would argue. So some of the questions that Peter and all talk about, and actually this is quite important because I've, in the many classes and the research that I do in this area, it's very easy to get kind of caught up in a trap and create research questions, which are your compass, as everyone knows who's a researcher in this room, and your guide, that aren't actually about implementation. So you need to really, really be clear about the kinds of questions you're asking. And so these are just some of the things that he suggests, which seem a little bit, I think quite intuitive. The other is the research needs to be conducted in a real world setting. It needs to be looking at the context. Too often in research, we don't do a very good job at describing the context. This poses huge problems for replication. And so then we say, oh, it doesn't work in my context, so I'm going to have to redo it again. When in fact, there are generalizable things that we can take from different contexts, but we need to do a better job at describing what that organization, for example, is doing, who's in charge, how decisions are made, what its health human resource complement are. Those are all descriptions of the institutional context, just to use one example. And then also, how does the research appropriately consider changes over time and the level of complexity? So those are, I think, just some of the questions that need to be asked when we're looking at this. In his paper, he also talks about many different concepts that are important to ask. I don't have time to go into all of them, but I think we're looking at the feasibility of implementation. So too often, why do things not work? Because they're not deemed to be feasible. Well, why is that? I think are important questions to ask. The coverage, so who is it reaching? And if we're not going to leave anyone behind, we need to again look at the equitable reach, and what does that mean? How well is that intervention being adapted or adopted in a different context? What are the needs of the different users? Is the intervention acceptable, appropriate? These are the kinds of questions that are important to ask that don't often get asked, and then we find that community readiness and community engagement contributed to that. So a few sort of question areas that I think are important to tackle. For example, acceptability. So is the intervention satisfactory to the audience it's trying to reach, both in terms of its content? Is it something that can be delivered? Is the agent or the agency delivering it credible? These are all sort of kinds of questions you can turn into research questions that look at the acceptability of an intervention. Adoption, this is really around, can we get organizations to take certain things up, practices, and I'll come back to some examples in a moment. Appropriateness really looks at the compatibility with institutions and their context, how useful it is, how practical it is. I mean, all of these things seem probably quite intuitive, but we're not asking these kinds of questions enough in our research designs to find out how interventions can get scaled up and implemented to full effect. So I guess one of my favorite examples to illustrate some of these points is insecticide-treated bed nets. So I think we all know that they, can reduce childhood malaria episodes by 50% and deaths by 20%, or according to some of the more recent numbers. But there's considerable debate about how best to deliver these nets. So before I show you the next slide, I want to ask, what kind of questions might help us understand how to implement these? Okay, it's your turn now. I warned you. Dawn?
You did mention the word consent, and in research, generally you're seeking consent, but here you've got implementation or an intervention. And should people ask for consent to do an intervention?
Yep. Yep, and I will come back to it at the end, but I have a whole set of slides on ethics, but thank you for raising it. Yes. And introduce yourself when you, just really quickly. Yeah, that's okay. Yeah, yeah, exactly. Others? Yes.
And Venezuela from the Guild. Do they want it? Is it acceptable? Do they use it?
So trying to get at some of those. And what might influence those kinds of questions? Can I ask you a little follow-up? Like the norms, perhaps, or other things that we don't always think? Will they value it, and how they value it?
I worked at the Thai-Burma border, and there you have a different mosquito. It's a dusk and dawn biter, and that's when people are not necessarily sleeping in their nets. So bed nets were completely useless.
Useless, yeah. Yeah, so they don't see the relevance to their context. That's a great example. Yes, can introduce yourself too. And
I'd ask questions such as like, how do you compare different mechanisms of delivering the net? So you have NGO delivering it, you have the state delivering it, you have private companies. If you have community members, what are the ratios of how many nets per person? And also tie that into how long are people using those nets and what is the reach of those different mechanisms we're discussing?
yeah, no, I think that's really important. The who and their credibility too with community in terms of if it's acceptable. Yes.
My name's Admiral. I'm from McMaster. Where is the malaria? Where is it most prevalent? Are there certain places where there are more dense populations or where there's easy access to transportation to deliver malaria?
Yeah, yeah. So again, sort of contextual factors you're talking about. Yes.
Hi, Dan from McMaster.
Oh, sorry. Yeah, it's okay.
I was going to say, if it has not been defined yet, maybe one good thing is to clearly define what is the scale that you're trying to measure effectiveness of things. Right? What will constitute a good delivery of badness and what will constitute a poor delivery?
Yeah.
Depends on the metric sets.
Yep. So what does success look like, right? In that context, again, in that context, right? Like, yes, go ahead.
Chris Arsenault, also McMaster. I don't even know how to pose this in terms of a question, but what of just, maybe we don't know every question that we need to relevantly ask. So what of even just posing the intervention to people as, like, would this work? Why not? What do you know about this plan that would make it go awry or would make it work right?
Right. Yeah, and actually that could be an example of, research that's participatory to find out whether the community is ready and what some of those barriers are before you actually roll out the thing, right? Yeah. Back there? Can you say your name too, please?
One question I have to ask, like in Haiti, we had this net, and then one question whether it's about safety, whether it's flammable. So
Flammable, yeah, good point.
they use water for that, and they can use it if there's no electricity. So the product in those nets, when they use it like in their own homes, and whether it's safe really for them to use.
Yeah. Yes, over here? Yes.
It's tied.
Oh, sorry. No, over there? Yes, red dress. Did you have your hand up again? Oh, sorry. Okay, I'll come back after. Yes, go ahead.
So I was actually in Uganda in June, and I actually saw bed nets being used incorrectly all the time. And so the types of questions that come to mind for me are definitely contextual. My name's Jonia, by the way. Last I realized it.
Well, it's a big McMaster turnout.
So I would ask, like, what are the sleeping practices in the community that you're going to, what types of things are missing in their homes, perhaps, that they're using bed nets as a substitution for. So I saw them being like hung, and then having pots in there. So what's missing that they see this as a tool outside of what it's meant to be used for?
Okay. I think over there and then Jan. Yes, go ahead. Erica? Right. Good point. Jan, and then I'll come back to you. Yep.
So I'd be interested in looking at where it wasn't working, where was it working, so the fails have occurred.
Yeah.
As opposed to where it's always worked in the past, and what does the evidence say about where it's not working? So that's then we get a better sense about not just effectiveness, but effectiveness. And I think that whole thing, that we're not forcing that on every intervention and every program, even though we have the tools now, I think it's something.
Yeah, I couldn't agree more. I think, Melanie?
It's tied to what someone over there said. It's a question of defining right from get-go what you mean by deliver. From a programmatic point of view, what does deliver mean?
Yep. No, I think it's absolutely correct. Yes?
How are the nets made, and is it possible for communities to make their own nets to deliver?
Okay. So I know that over the last 10 years, we've certainly learned from the evidence. However, I'm just going to cite the results from one study that basically showed that the most popular reasons for the bed nets not being used as intended, because of course was because the bed nets were inexpensive or free, and it allowed them to dry the fish better. So, and in other cases, it was actually used for fishing. And this is not just, let me be very clear, this is not just solving it by saying, oh, here is how to use this, like an education solution to this. On the contrary, I would argue that, and we know this, that many knew what it was for, but they valued it in a different way. It had a better value in this case. And when you plunk these things into context and don't understand that there may be a better use for it, who are we to say that you should use a net, which is intended for the prevention of malaria, to use it in a different way? So I just think it's in one of, and I'm sure we have many other examples of how that's happened. But this is, I think, a really good example of failing to understand the context in which. So why might context be important in implementation research? I think many of your answers and the types of questions you were generating started to get at some of that. And this is actually a really good paper, and I'm not just, it's a shout out to my former boss, but Nancy Edwards and Pierre Barker have written this paper actually in the, it's an AIDS journal, and it looks at context and how it's important in implementation research. So you can't see that, but don't worry, you will get that. I tried 7 times to get this to look clearer, and then I gave up. But I will give you the slides, and so what I just want to highlight here is that in the paper that Nancy and Pierre actually did, they looked at what are called contextual elements and their application in designing intervention protocols. And so these are just 3 studies that I've put up here, but I'll read them out to you just to give you a sense. And actually, many of your comments alluded to this. So some of the studies that they analyzed through their review of the literature, where context was actually explicit, did certain things. They actually looked at cultural practices and gender norms in relation to interventions, and that it helped to shape the way the intervention was designed. So you remember the diagram I showed at the very beginning? many of these kinds of questions can be thought of at all different life stages of a program, if pardon the expression. So in that case, that was important, and it was critical to look at gender-focused interventions. In other cases, they did a better job at the characteristics of the study population and a better understanding of the community, and what were the patterns of poverty, employment, so all of those determinants that are reflected in the SDGs. Who owned mobile phones, because in some cases they were looking to implement interventions that had that as a component. I know it seems self-evident, but this is kind of like doing your homework in a way to better understand what are the conditions under which something might get implemented. And then in other studies, they looked at things like what were the characteristics of the health facilities, who was in charge, how far did people need to travel to get to different health facilities, who was offering these things. These are just examples. There are many, many more. But the point being that context is really important to better understand if you really want to roll out an intervention. Another example that I wanted to highlight with you is, so this is a paper in the Lancet, and what this paper did was they summarized different models for scaling up interventions, and what Knight did in critiquing the Smith et al. Paper that's identified there at the bottom, called Maximizing Health HIV Prevention by Balancing the Opportunity of Today with the Promises of Tomorrow, the modeling study failed to take into account the laws and their enforcement, and in so doing, they missed an important part of the context. So you're all nodding your heads thinking, oh, of course, yeah, but we continue to produce studies like this that don't do this, and then we have critiques like this. And so, of course, it made a difference, and so they were reviewing several interventions in sub-Saharan Africa, but failed to take into account, for example, in South Africa, the fact that sex work is criminalized. They didn't control or take into account in their models, for example, in Nigeria, that the legislation that exists criminalizes same-sex sexuality, and that it could lead to people avoiding the use of the healthcare system because the healthcare system is actually perpetuating that form of discrimination. So again, this seems like it's self-evident, but we're continuing to produce studies that don't actually attend to these things, and I guess that's kind of what I'm trying to alert you to. In another study that looked at implementation research for the prevention of mother-to-child HIV transmission in sub-Saharan Africa, they looked at a number of gaps and opportunities. And so some of the lessons that they found were that greater emphasis on context, fidelity, and scalability in the design of these and dissemination of these studies would actually enhance efforts and provide the basis for future evidence-based programs. So before I go any further, I think you understand now what context is, but who has heard of the concept fidelity? Because it actually starts to get at some of the questions you were raising. Yes?
So fidelity is the degree to which your intervention is implemented as intended. So if you said you're going to select a community health worker from the community, you only have 50% of the cases where that's true, and the other 50% the local council selected them. When you come to measure the impact of your interventions, are you going to work or did it not work? You don't really know because you actually don't have confidence in the fidelity of how it's implemented.
Any other thoughts on fidelity? Dawn, did you want to put up your... I think one of the challenges, of course, in studies like this, though, is while that's important, it's sometimes difficult to come up with the right kinds of measures to assess fidelity. And often context gets blamed for something not actually being implemented as intended. And I would argue that part of the reason for that is that if an intervention is going to actually work, it may need to adapt to the context to be actually, it needs to do that. So there's a tension there between fidelity and context at times that we see in the literature. Yep.
My name is Steven. I'm from LSE. I just have a question. There's seemingly like infinite questions we can ask, infinite contextual factors to consider. From like a programmatic perspective, it's impossible to fulfill all of those. So what do you do in that case when you have limited resources and you have to like try to prioritize or like triage which context?
Yeah, no, I think that's a really good point. I mean, at the end of the day, there are going to be things that you're going to leave out because of the choices you make. So there are two ways I could answer that. One is I think we need to be a lot more transparent about the assumptions that underlie the kinds of questions we're asking and therefore what we're not asking. And, you know, at the risk of sounding obvious, I think having very good governance mechanisms where research is done with and by and for community, however that's defined, is also quite important, but has resource implications, so, and difficult to finance for sure. But yeah, very important question. I think the last 2 points, certainly I've talked about a little bit around the importance of context. So lots of unanswered questions. Yeah, you scoop me. No, it's okay. And so this is, and you'll get these slides, but in the paper that David Peters has outlined, what he does is a really nice job from the left side where he'll talk about some of the different scenarios where you have implementation was relevant but was not considered, to this side where he talks about implementation as the primary focus. And it's very useful, and I go back to it a lot because it's kind of a good way to sort of check your own questions about whether, and again, not to say that you shouldn't be asking other kinds of research, but if you're going to do implementation research, important to look at how do parts of a program change and why? What are kind of the effects of the actual implementation strategies? Looking at variables of implementation as your primary outcomes as opposed to some secondary thing. I mean, these are all things, and the kinds of methods, which are, you'll see RCT is not on this list. It's mixed methods, quasi-experimental designs, and there are, you know, threats to validity when you apply some of these, but there are very good strategies for mitigating that. So this is just to show you that it's important to sort of situate yourself if you're interested in doing this kind of work. I think I just wanted to go back to this slide really quickly. So thanks very much for engaging in that. So just back to this article, I think one of the mother-to-child transmission examples that they looked at really understood women in the settings that they were seeking care and what were some of the social and cultural norms. So you touched on that were actually limiting individual access to medical attention. And so by putting these interventions in those facilities that women weren't even accessing, led to a major failure in uptake. So, and so these were some of the, and this happened after, according to the authors, a series, not just one, a series of randomized trials. So they kept trying to replicate this. So I think there's a lot of waste that can sometimes go in if we don't ask these kinds of other questions. So I'm not trying to pit RCTs against the rest here, but I think in some cases we have to just be mindful that they're not always going to get at why are certain patients in this case poorly adhering to something, or why are women refusing a service outright, you know? And so we need to be, I think, better attuned to what are patient preferences, how do people like to access services, that kind of thing comes from some of the kinds of questions that you've been asking. So I'm just going to wrap up now and just talk a little bit about ethics and knowledge translation. And so again, this could be an entire lecture onto itself, but there are, I think, many important intersections between questions of ethics and this kind of research. If you haven't heard this already from me, I'll say it again, but I think the importance of negotiating community perspectives and interests actually don't always align or can conflict with researcher perspectives and interests in the research process. And so I think Dawn's question earlier was starting to get at that. And there are huge power asymmetries that we need to be very mindful of as researchers in any implementation context. So the equity dimension, again, if there's one thing you take away, really has to be at the forefront in not just the way we design interventions, but how we implement them and evaluate them. And, you know, I think we're getting there, but we need to do a better job at figuring out ways in which, whether just the intervention is reached, and that's why I pushed you a little bit on the question, you know, acceptable for whom? And acceptable for whom and who is being left behind, right, as a result, because you're not asking the equity question. And then there's some ethics related to scale up. So the more you make something available, and by definition scale it up, there are opportunity costs, not just for those who are implementing it, but for communities and for health systems. So for example, what is a new intervention that is introduced into a health system competing with, right? And so that is, I think this group in the middle, in your analysis, talked about, well, what other interventions are going on? That's important for this reason. It's also important for very pragmatic reasons, which is that very intervention could be competing with the one you're trying to introduce, and yours will not have a hope in heck of actually making it, because or conversely, the new intervention may not be the right thing to help communities, for example, but it may displace previous interventions that were working very well. And we've seen this actually in the case of Pap smears and HIV vaccine as an example. So in another really good article by James Lavery, I don't know if you know him, he's now at Emory, but was at U of T, that he argues that for wicked problems, it's important to look at community engagement and that we need an implementation science for research ethics. So he challenges, I think, academic institutions to look beyond their core roles and to consider how to contribute more fully to the public good. And that's really important when we're talking about interventions that need to be scaled up. And I'll just let you read that, what he says here. And then around knowledge translation and exchange, so I think you may also wonder, okay, what does implementation research have to do with knowledge translation and exchange? And I think implementation research is a form of very applied research. So I'm artificially distinguishing these concepts, but often when we're trying to generate research through implementation lens, we're also trying to apply it so that it can improve programs, it can strengthen programs, and hopefully allow also programs to stop. I have a bit of a bugaboo that we don't do that enough, where we're constantly introducing new things into health systems and sectors, but we also have to stop doing things, as I said this morning. I think that means that we need to do a better job in terms of understanding who the actors are who are engaged in the research process. This notion of co-construction of knowledge, which is very, very important, working with communities, and having governance structures that actually stand the test, I think, of making this co-construction important, and being sensitive to the voices that are being heard and not heard. We know that some methods in research actually strip out certain voices by design, and we just have to be, I think, very honest about the kinds of voices that are left behind and not part of our summaries. Too often we're looking for, when we do thematic analyses, for example, what's the most common prevalent perspective or theme? And while that's important, we may also learn a lot from the outliers as well, and we shouldn't ignore those. Is I guess the final point. And so I guess some of the intersections that we need to pay attention to is how are we better capturing ethical consideration in our studies? And I'm not just talking about getting consent from communities, which is of course important, but also looking at what are some of the ethical foundations of some of the interventions. Are they actually increasing inequities? And if we don't measure that, how would we know? And finally, again, as I mentioned before, what are some of the unintended consequences? We don't like to ask those kinds of questions, but I think we have to, and because in some cases the very interventions that we're trying to implement and test and evaluate may end up further labeling and stigmatizing communities and reinforcing individual responsibility. So for example, and that's why when I go back to the malaria example, some people may be quick to judge and to say, well, we should have just educated people to know what these nets are for, when in fact that is a very simplistic and blaming the victim perspective on that question. It's much more complex than that. So I thank you for your time, and it was a pleasure to spend this afternoon with you, and thanks for your attention and for attending.